Welcome everyone to the webinar of the Lancet Citizens Commission on Reimagining India's Health System. As you know, the Lancet Commission is an ambitious cross-sectional endeavor that aims to lay out a citizen's roadmap to achieving universal health coverage for people of India. It will be a comprehensive research effort that brings together key stakeholders across social spectrum. The Commission's monthly webinar series serves as a platform for public health discourse in India and a means for academicians, practitioners, and public to engage on substantive and timely issues regarding universal health coverage in India. Today's webinar is on role of AYUSH systems in achieving universal health coverage in India. It is being co-hosted with the Savitribai Phule Pune University and Dr. D.Y. Patil Vidyapeeth in Pune. The panelists today will focus on the potential of Ayurveda, Yoga, Unani, Siddha, Sowa Rigpa and Naturopathy and Homeopathy together in India known as AYUSH systems for public health in India. We will discuss the role AYUSH can play in achieving universal health coverage in India and the challenges in utilizing it. There will also be a short survey at the end of the webinar. Please do fill it out and let us know your thoughts and suggestions about the topic and future webinars you would like to see. Finally, you can sign up to receive the Commission's newsletter alerts for future webinars and events on our website. Now, I would like to invite our keynote speaker, Professor Darshan Shankar. Professor Shankar is a true evangelist of local health tradition and traditional medicine, who, with Dr. Sam Pitroda, founded Foundation for Revitalization of Local Health Tradition, also known as FRLST in Bangalore. Currently, he is the Vice Chancellor of Disciplinary University in Bangalore. He is recipient of Padma Shri and many other awards. Professor Darshan, over to you, please.
Thank you, Bhushan, and my greetings to my fellow panelists and hopefully to a receptive audience. Universal health coverage is delivered by national health systems. The national health systems have multiple dimensions, like the philosophy of the medical systems, the knowledge content, the design of health delivery, the governance, finance, technology, community participation, ethics and values, and today emerging cross-sectoral links like One Health and planetary health. I will only review the knowledge content of universal health coverage in India, which is currently dominated by biomedicine. My fellow panelists will share other perspectives, including philosophy of medical systems, community health practices that are seen in this country, and emerging Asian models of integrative healthcare delivery. Why is there a need for a serious review of the dominance of biomedicine? The reasons essentially are there are very poor outcomes of biomedicine that even after decades of execution, a very large proportion of our population, over 60%, some data says 70% of the population, they spend out of pocket. In other words, UHC doesn't cover them. So there are very poor outcomes. This lack of coverage is costly for citizens, and health expenditure is, as we know, the main cause for rural indebtedness. There are also examples of glaring ineffective interventions. And an example is the situation in respect of iron deficiency anemia, where even after several decades of effort, we have no change in the situation. And it appears to be an example of both poor science and public health practice. Biomedicine claims a dominant role because it is seen to be evidence-based medicine. I believe, with no intent to offend anybody, I believe this is a myth. There is a need for a serious review of the quality of evidence underlying biomedicine's public health interventions. Evidence, as you know, as statisticians know, is a nuanced term. It includes several qualitative grades, evidence of quality A, B, C, and so on and so forth. A critical analysis is needed today, given the poor performance of UHC, to identify the grades of evidence that underlie different specific public health interventions. Now, ground reality does suggest that the quality of evidence is poor. You can see this firstly from health-seeking behavior all over the world, in fact, where studies, even those conducted by the World Health Organization, show that 40 to 70% of the population show lack of confidence in Western biomedicine knowledge as the panacea for all their needs. So for specific needs, they do go to the mainstream, but 40 to 70% do not go to biomedicine for all their needs. Since 1960, and my data may not be updated, there are over 200 cases of previously certified drugs who have gone through phase 1, phase up to 5 trials and have been subsequently banned on grounds of public safety. Furthermore, on the matter of evidence, we know at the frontiers of biology that biomedical sciences have serious limitations in terms of the experimental pharmacology models that they use. We know that when we are talking of a futuristic thing like body on a chip, about the limitations of the fractured, currently used bioassays and models to understand complexity and interconnectedness, the huge complexity and interconnectedness of the human biome. In other words, experimental pharmacology does not mimic life adequately, and therefore does not provide us enough, validated knowledge about biological activity, experimental pharmacology. The same is the situation which many people do not realize in clinical pharmacology. The best clinical trials anywhere in the world have ignored variability in the sampling design, in the inclusion and exclusion criteria. They treat heterogeneous populations or samples as homogeneous and test uniform interventions. So uniform interventions for heterogeneous populations treated as homogeneous. In the 21st century, I believe we need new research paradigms, strategies, and models. We must begin to look at practice-based evidence, PBE, in place of only randomized controlled trials. Real-world, longitudinal, retrospective, perhaps 10 years clinical data from the most reputed clinical establishments may be a more reliable method to reassess clinical evidence and public acceptance of both biomedicine as well as AYUSH. Practice-based evidence is really today at the perhaps a new higher end of the pyramid of evidence. Personalization of food and medicine is the future of healthcare. This will need to begin with decolonization of health science knowledge systems in all developing societies, not only India. Towards personalization, India has been pioneering cross-cultural paradigms in research like Ayurgenomics, like the framework of Ayurveda biology and reverse pharmacology. The 21st century needs a completely new health research agendas related to wellness, not only disease management, related to bioregulation and homeostasis, relating to general immunity, not only specific immunity, relating to a completely new genera of drugs which are multi-targeted. And of course, we will need in this 21st century a great deal of community empowerment. Coming to the Indian universal health coverage context, there are three central assumptions underlying India's integrative strategy for universal health coverage. These assumptions were first advocated in 2005 in the National Rural Health Mission, subsequently in the National Health Mission of 2013. They are very clearly articulated in India's latest health policy 2017, and also incorporated in the latest avatar of universal health coverage strategy called the Ayushman Bharat Health and Wellness Centers 2020. In all these platforms, the government, there are three assumptions. A single medical system cannot deliver universal health coverage. This is the first assumption. The second is a strong recommendation that AYUSH systems need to be integrated into all the three tiers, primary, secondary, and tertiary. And a fourth very interesting recommendation in the official universal health coverage strategy of the government of India is introducing an innovation of a fourth community-based tier, a tier to empower communities, a non-institutional fourth tier. This is a very revolutionary idea in India's universal health coverage strategy. I'll just speak very briefly, and this is my last slide, on community empowerment and operationalizing of the fourth tier. In this tier, we need to design and execute digital, multilingual, integrative strategies directed at homes as the providers. We need to introduce Green One Health in every single taluka of this country based on reliable use of specific medicinal flora, ecosystem-specific medicinal flora. We need to focus on a very ambitious program which can be delivered through the fourth tier on mass personalization of food, based on a national integrative nutritional database, which will need to be powered with artificial intelligence and machine learning so that citizens can access it even on an Android app. We need to ensure pathogen-free, safe drinking water by the lowest cost method of making drinking water pathogen-free, which is ensuring contact of drinking water with copper. Never mind where the water is stored. It can be in mud pots, aluminum pots, plastic pots. If there is copper put in contact, and these experiments have been done on field levels and labs, you can ensure pathogen-free and safe drinking water. Finally, we need to use the community platforms in our country, in our rural areas, to introduce training in yoga for mental health. So that's all that I have to say in my opening remarks. Thank you very much. And we should all look forward to the comments from our panelists.
Thanks, Professor Darshan, for that thought-provoking keynote. You talked about the knowledge content part of the USC, and now we have a panelist, who will talk about some other aspects of it. I think we have panelists, including one who will talk about the basic philosophy behind all this, And before I give it to other panelists, I'm going to really request Sarika Chaturvedi to take on further. I must tell you that Sarika brings a very unique background. She graduated in Ayurvedic medicine, so she did BAMS from Pune, and then she completed her master's in health systems management and completed her PhD in public health from Karolinska Institute in Sweden. Her interests are in integrative health, quality of care of women's and children's health, traditional health practices, and public health policy. Sarika currently is scientist at Dr. D.Y. Patil University in Pune, and she will take you further with the other eminent panelists. Over to you, Sarika.
Thank you, sir. Thank you for the kind words and this opportunity to be here. We are very happy indeed to have a very eminent panel here to continue this discussion after that thought-provoking presentation by Darshanji. It's difficult to introduce the panelists fully for they have so many contributions to this field, but I'll just mention very few highlights as much is available online for us to know about them. Professor John Porter is here with us. He's a Professor Emeritus at the London School and Professor of International Health. Dr. Porter trained in medicine and pediatrics in London and then in public health in the US and UK, where he was focusing on infectious disease control. And that took him to interest in health systems, policy, and ethics. His recent work focuses on population self-reliance in health, much closer to the fourth tier that Professor Darshan Shankar mentioned of. Professor Porter has authored some of the very key papers in the area of AYUSH policies in the recent 2 decades in India. Very happy to have you here, Dr. Porter. Welcome. Our panelist, Dr. Leena Abraham, comes from sociology. She's a professor at the Tata Institute of Social Sciences with her research in sociology of medicine and sociology of education. Her work focuses on medical pluralism, politics of knowledge systems, Ayurveda education, and science-culture interface. She's currently researching on societal groups and power structures in the field of Ayurveda that very few people talk about. Of her several scholarly works that she's authored, I'll mention here particularly of her book, Medical Pluralism in Contemporary India, that she has co-edited. We have here with Dr. Geeta Krishnan Gopal Krishnan Pillai from the World Health Organization's Traditional Complementary and Integrative Medicine Unit. He's a popular name in this field, and he's specialized in Ayurveda, and he's taken his fellowship in integrative medicine in Germany. Dr. Krishnan's research in integrative medicine spans diverse areas, such as drug development, for which he has several patents in both national and international. He's been interested in integrated clinical management, as he headed the integrative medicine unit at the Medanta Hospital, where he's a physician as well as a researcher and conducted several studies there. He's also worked a lot in health policy and has been an active member of the AYUSH initiatives for COVID in several countries, including those of the Ministry of AYUSH in India, and has been very closely involved with the work of the Niti Aayog in India on the health policy front. Very happy to have you here, Dr. Pillai, and thank you for making it. So without spending more time, I think we can start the panel discussion, as we are eager to hear your thoughts on this. We heard Dr. Darshan Shankar talk about biomedicalization. Dr. Porter, would you share with us your thoughts on this view of Ayush systems in India, and how do you see the role of Ayush systems for public health in India vis-a-vis the complementary alternative medicine or traditional medicine in global health?
Thank you very much, Sarika, and thank you for inviting me to be on this panel. And thank you, Darshan Shankar, for a really excellent presentation that for me has set the scene very well. I'm going to pick up particularly this issue around the biomedicalization, in the sense of healthcare around the world. But before I do that, I just want to concentrate on the word universal. So when I was thinking about points that I might make, this issue of universal health coverage, what is universal? And we're in the midst of a climate crisis. We've just had the COP26 in the UK a few weeks ago. And something that was very striking about that is that we still remain very human-centric in our approach. And as we know, health is really all about balance. And the Ayush systems all have a much stronger understanding of the balance of nature and the balance of nature of which we are a part. Whereas the biomedical system on the whole does not really concentrate so much on that. It's very human-centric. And so this aspect of balance and integration in terms of these different traditions combating or trying to balance biomedicine is a real issue. And I think it's important, sitting in the West, when we talk about science, we're really talking about science from the 16th century in Europe. It's a particular definition of science, and it has led to this extraordinary world that we now live in, which is very technologically based. And we have health systems that are increasingly technologically based, increasingly structured. And that is fine in one sense, but it's really not from the point of view of balance, homeostasis, and nature. So I think my first point in terms of the different systems is that TCAM, AYUSH, these are systems that are required for integration. So we have to find a way of combating the power of the biomedical structures. And in some senses, it's very simple, because biomedicine, however much we talk about health within biomedicine, and I'm a public health practitioner and also a clinician, we really are focusing on disease. So I've been training in disease control, in a sense, from the age of 18. And it's very difficult to make a shift from that into what health is. And I find these much wider perspectives that are contained within the Ayush systems and in the whole concept of nature and ecology incredibly important in that process. Just before I finish, I want to also mention the economic aspects, and this is an important part for research. The economic structures that we work with have been, in a sense, emerged from this particular model of biomedicine. So when we look at the economic structures that we work with, they've come over the past century or so, and they are focusing on things like gross domestic product. They don't focus on health. So gross national happiness and work that's being done by other particularly Asian systems is extremely important in a way of trying to create balance within those systems. And the other issue is really around the fourth tier, which Darshan Shankar has already mentioned. And I will have an opportunity, I think, later on to talk a bit about that. So thank you.
Thank you, Professor Porter, for that very useful remarks on to take us further. We've talked a lot about the global scenario and you worked so much on that, but I would now like to hear some local perspectives on that. we often talk of understanding the user's choices, and now there's a global acceptance to that, the need to understand the user's choices and the cultural roots of this. Dr. Leena Abram, would you like to talk to us on the health culture linkages and the implications of these, especially on access and utilization of services?
Thank you, Sarika. And thank you, Darshan and John, for putting out some of these important remarks. I will basically talk about the information and perspectives coming from people's choices and people's health-seeking behaviors and practices. In India, we have a large number of studies from 1950s onwards, looking at people's health-seeking. Now, health-seeking behavior generally refers to these remedial actions that individuals and families or even societal groups take in response to perceived ill health. Now, these actions could be based on a number of factors, the severity of the condition, the socioeconomic status of the affected individuals, and also their general bargaining power within families and communities, then availability and accessibility of services, perceived quality of these services, very importantly, the cost of treatment, and of course, healthcare knowledge and practices embedded in the local culture. Now, we know that this set of factors actually include both ideological and material factors, and they actually work together in complex ways to influence people's health seeking. So if we look at if you review the studies, which I referred to earlier from 1950s onwards, what we find is that, a combination of these factors in different permutations, actually, working on the ground in influencing people's choices. But what we find in these studies is that most households, across the country, irrespective of the availability and quality of services, they were found to be following pluralistic health practices, which involves home remedies as well as multiple systems of medicine. I will talk later, perhaps if there is an opportunity, about certain features of these pluralistic medical practices. But here I want to draw attention to the certain trends that you see in these studies. So in the earlier studies, you find that many of them concluding that people resort to home remedies and other systems of medicine, systems other than biomedicine, because biomedicine services were not available to them, or because they were largely illiterate and ignorant. So this seems to be the kind of general conclusion of many of the earlier studies. But in more later studies, we find that people continue to be using home remedies and multiple medical systems, even when high quality biomedical facilities, both in the public and private sectors, are available to them. Say if you take, cities like Delhi or, Chennai and Kolkata, or even a state like Kerala, where both biomedical and other systems are available to people of certain quality, both in the government sector as well as in the private sector. Now, we also found that these pluralistic practices were followed by the urban and the educated groups. And interestingly, in one of the recent study on health seeking among the middle class during the early phase of COVID-19 and the lockdown across 10 cities in India, conducted by the Holistic Health Systems Research, showed that people followed home remedies as a preventive strategy. while they followed, 90% of them followed this mandatory precautions, about more than 50% followed various home remedies. And this was found across these 10 cities among the middle classes. So you see that home remedies are used extensively by people across the country. Now, coming back to the earlier studies, they have reported the reasons for people's use of plural medical practices to include, one is the easy access and the usefulness of many of these remedies, the high cost of biomedical treatment and hospitalization, then the adverse or side effects of biomedical treatments, perceived or experienced. And many of them found treating or managing various chronic illnesses with the help of multiple systems very useful. So people were making choices using certain criteria to evaluate medical systems, primarily based on the overall effectiveness of therapeutic outcomes and cost of care. So there seems to be a strong culture of self-care involving home remedies while making choices to secure best outcomes. So in this context, I think it is important to take note of this aspect of people's healthcare practices, while designing a universal health coverage. And I will maybe talk a little bit about the regional differences and diversities later on. Thank you, Sarika.
Yeah, thank you, Dr. Lina. That was very enlightening, and it was very also good to note that you have told us why this might not have changed despite increased access to services or biomedical care or availability of care, or even the ability to afford care. And there is something more to it than just availability. Taking from there, what I would like to hear from you, Dr. Geeta Krishnan Pillai, if you could, I would request you to tell us about the distinctions of traditional medicine systems in countries with good and poor health coverage. What are the conditions where these systems, traditional systems, are used more formally and systematically than where they are not used so formally?
Thank you, Dr. Sarika, for asking this very relevant question. Thanks, Dr. Darshan Shankar, Dr. John Potter, Dr. Lina Abraham for having set this foundation for the discussion that we are having today. As you asked, this is a very, very relevant question because we know that we are using in India AYUSH systems quite a lot. But it is also interesting, or would be interesting, to learn from others who are using it and not using it, probably. Like we can understand from the gains and the mistakes which people make in different societies. So if you look at, other than India, if you look at the most important country who has been using traditional medicine very effectively, no doubt is China. Has, is very well established in health system, has been using traditional medicine on a variety of things, and very effectively, very very economically, and broadly in many facets of healthcare. But I think China is a very well-known example. So we should go to other areas where we might think traditional medicine might not be so very well used. I would like to bring to your notice the example of Sri Lanka. Sri Lanka is an excellent example to understand how traditional medicine is being used as a community healthcare tool, where dengue management is one of the major examples which we can actually point out how when traditional medicine was used very effectively in community engagement and making sure that dengue-free situation could be brought about much faster. The example of Sri Lanka in dengue management is a global global study to understand how traditional medicine and modern medicine can work together in health system. Another area where you asked, where you might think in a high income country where modern medical facilities are very well utilized, but has turned to traditional medicine for appropriate management based on people's choice is Switzerland, like where the World Health Organization is residing. So in Switzerland, the people decided over in the past 10-15 years that they require traditional medicine or different other systems of health interventions that can improve their health, and they have made legislations, and at this particular moment Ayurveda is a registered medical practice in Switzerland, and so there is a possibility of Ayurvedic practitioners to go and practice in Switzerland. And so you should understand that from a low middle income country to a high income country, traditional medicine can be utilized very effectively if the policy makers and the health system can understand what it requires and the correct policies are made. That's the real point, And in another example, I would also like to just bring one more example to you, which is regarding United Arab Emirates, like a country where most of the people are expats. In fact, more than only 1/3 of the human population in that area or in that geographical location actually are real inhabitants from the same place, but most of them are expats. They have chosen to change legislation so that the expat community can access traditional medicine, which they are more used to, and can have better healthcare within the health system itself. So there are different models which have evolved in the world, and we should understand, as one of the time in one of our earlier discussions you had said that India is a conglomerate of different countries within the same country, within one country. We have a lot to learn from each of these models, but we cannot exactly copy and paste what is happening in different situations into a one nation, one country of India, because we have different situations. We have to understand what our requirements are according to the social requirement, and make those that specific choices, which Dr. Leena very clearly mentioned while she was giving her talk. Thank you.
Yeah, Dr. Geeta Krishna, I'll come back to you again for more on what we could pick up from different paths when we think about bringing this system more in a better way in the Indian scenario. But before that, I would like to request Dr. Porter to tell us a little more about the 4th tier that you've been advocating for, and how do you see it in light of the attempts for universal health coverage? Dr. Darshan Shankar also mentioned about it coming in formally in the policy document for the Indian government, and we've been closely involved with that. Could you expand on that here, please?
Yes, I think it's, for me, it's come very much from what's required here also is a shift in philosophy. We've got to get much bigger in the way we look at this issue. And as I've already said, biomedicine is in a sense very constrained. And in terms of health, coming from the 16th century philosophers in Europe, it divided the body from the mind. So that's just the nature of the way the system's gone. And the medical industrial complex that's been created, which we work within, which sits within all our health systems, primary, secondary, and tertiary, sits within that philosophy. And AYUSH doesn't. Traditional Chinese medicine doesn't. The philosophy is much bigger. And I'm even encouraging it to go even bigger towards looking at the philosophy of nature, and so involving the ecological stories as well. So the 4th tier for me is a real wake-up call in terms of how we currently look at our health systems. And they are internationally very biomedical. I mean, primary, secondary, and tertiary. So even when we go down to talking about universal health coverage back in the 70s in the primary healthcare center, it still sits within this biomedical philosophy. So the fourth tier is a real shift into, well, what about the population? Where are they in our whole ethos of our health system? How important are they? What's their contribution? And currently it's really not there economically, for example. We don't think about how the local populations actually contribute to health and therefore to the whole health system. So the fourth tier for me is a real shift in values also around dignity and respect of individuals and trust in community. Very much about individual, around relationships and around communities. And it's about population self-reliance. So as both Lena and Gita have already mentioned, individuals find their own ways of finding balance. They find their own ways to look for health. And if the systems are not functioning, as they haven't been particularly well in certain countries around COVID, people will get on with it. And the more they're educated and encouraged to do that, then I think, when our next crisis comes with an infectious disease, for example, these populations will be much more aware of their knowledge and able to deal with the situation in a much, much broader way than we currently do. So the fourth tier, which is around population self-reliance and health. And for me personally, as I've been learning over the years about Ayurveda, the concept of svasthya, of being rooted within, for me was a really revolutionary concept in terms of my background as a medical practitioner, and this concept of something rooted within me that is all to do with my health. And that sits within the AYUSH systems, and particularly yoga, for example, but also Ayurveda. So India has this unbelievable knowledge. And as Gita is also saying, just from the point of view of every state is completely unique. They all have their own extraordinarily unique systems. And we need to find out more about them. India needs to do that, but we need that information internationally, desperately, to improve our systems in the West and to encourage the development of so-called alternative practices in the UK, for example. And a lot of that for me is around very basic values of things like care, balance, and just thinking in the UK at the moment, all the community efforts that are going on to support the population while we're in the pandemic. And at the same time, we have an act going through Parliament, or a discussion in Parliament at the moment, to do with the National Health Service, where there's huge concern around the breakup of the system and the commercialization of the system, and basically the medicalization of that system as a biomedical structure. And the systems you've got are important ways to help not only India, but for me, particularly the rest of the world, in finding a way to start to balance the dominant biomedical perspective, which is desperately, desperately needed. So the fourth tier for me is a really important lens into that world and the research that can be done in order to help policymakers, health systems people to become just much more aware of the populations that they're serving. And it's not all about disease. Disease is incredibly important, but in a sense, that's the end of the line. What you want to do is develop systems so you don't have disease. And Darshan's last slide, I think, highlighted some key points around the fourth tier. Thank you.
Thank you, Professor Porter, for talking about swasthya from being a medical practitioner and a teacher in the UK, and you've seen what it means from a different lens. That was very good to hear it from you, and I hope it also enlightens people within us, within here, to think more about swasthya, not only disease, but more about wellness as well. When we do that, we are, as you said, trained to think more in the medical industrial complex, to think about everything, to bring it to evidence-based medicine, and we start questioning everything with that paradigm, which may not always be right, or may be right in some places. Dr. Darshan Shankar, when he gave his keynote, he talked about practice-based evidence. Dr. Geeta Krishna, would you talk more on that and explain your views on that, the philosophy or the concept of practice-based evidence?
Oh, yes. Thank you, Dr. Sarika. I think traditional medicine basically is practice-based, and it is evidence-based since centuries. And it is quite like when I read papers, I find that, I find there is not enough evidence in traditional medicine to prove a certain kind of an intervention. This is a very, very common statement which we find across medical journals and or papers. I think it is not the right kind of word to use. Basically, this something which has been in use for centuries, which has been accepted by the community and in society, which does not need to be reviewed again and again to be deleted from the society's mind or memory. Like to call it not evidence-based won't be appropriate. So basically, something which is practiced, something which is effective, something which is safe, should be considered and utilized for the human health, and there should be a mechanism for that. And at this particular moment, the way in which the medical systems try to absorb knowledge or try to accept probably methods of clinical management is not very, very traditional medicine friendly or traditional knowledge friendly, or I would say even evidence of evidence based on practice friendly. So that change has to come, and that would be very important. I can tell you about several different areas where traditional medicine can be useful. One of them I could simply put forward is like, for example, psoriasis in the management of psoriasis by Siddha system of medicine, or the management of vitiligo by Unani system of medicine, or in a management of allergic asthma by Homeo system of medicine. Mental health by yoga, or back pain and knee joint pain by Ayurveda. These are unmet needs in the community, which is not addressed, and we are waiting, and it is being addressed. In one side, we see that millions of people are being cared and cured or managed with this for these problems by the AYUSH systems, whereas the medical community, or the community which accepts a system or an intervention as a medical program or a medical intervention, is waiting for evidence. I do not know what kind of evidence further we require than millions of people utilizing an intervention and finding it safe and effective. I think that's the most important evidence, and we lack a mechanism to accept it, and we need to create a mechanism to accept it. That is where I think the next innovation in traditional medicine, or next innovation in health system, needs to come, and that would be a major innovation, and that can really change the way in which traditional medicine gets integrated into health systems and support the community as a whole.
If I may intervene at this point, Sarita.
Yes, please.
I would like to add to what Geeta is saying. I believe that there is an entire now methodology available to document what we call real world clinical evidence or practice-based medicine. There's an entire methodology. I mean, if you look, what we need to do is we need to look at not only for traditional medicine, even for biomedicine. We need to look at 10 years minimum data of actual footfalls in the most reputed institutions of both the AYUSH and the biomedical system. If you look at 10 years of data of reputed institutions, let's say 100 reputed institutions, you're looking at several million records, over a 10-year period. You can use algorithms, you can use methods of analysis of machine learning and artificial intelligence to analyze this data. It's huge data. This is what will give you evidence of what is working. You don't, this is not a new thing. Today, at the frontiers of evidence theory and evidence practice, RCT or even meta-analysis of RCT is at a lower level of quality of evidence that it generates as compared to practice-based evidence data. So we don't want to talk of, how many centuries we have been using. Let's look at the last 10 years. And let's look at last 10 years of 100 good establishments. You're looking at a huge amount of data, and for both systems of medicine. And once you do this, you will actually be able to recalibrate, at least in terms of curative conditions, you'll be able to recalibrate on the basis of this data, what is the proportionate share that we should give to different systems of medicine based on hard ground reality. This is long overdue and we should be doing it.
Yeah, thank you, Darshanji, for coming in and bringing that point. And very relevant to this, we have a question here. You could just continue what you're saying from one of our commissioners, Dr. Tarun Khanna. He asked that we've heard from you about the limitations of statistical tests of biomedicine. But could you comment on the pros and cons of the extant state of statistical know-how of AYUSH efficacy? That's what he asked.
Yes, so I'll be happy to answer that question. You see, many people don't realize that data, research data or evidence-based data is directly a function of research investment. Absence of data is not tantamount to, you cannot infer from absence. There is very little research data in comparison with the extent of research data that is there in biomedicine. And you compare the amount of data that is available through studies, trials, and so on and so forth, in the AYUSH systems, it is negligible. Now, why is it negligible? Because the investment, if you want more data, you have to invest more. Now, the investments in the AYUSH system, so it's directly a function of investment. It is nothing to do with the effectiveness or efficacy of a system. You cannot infer from the absence of data that the system is incompetent. Absence of data simply means absence of investment. That's all. Now, if you look at 50 years of data, I have looked at it in the AYUSH systems from the 70s onwards, you will see in no single year in what we call extramural research has the government ever spent over about 10 crores or 1.5 million or something US dollars on research for the whole country. Now, what kind of data are you going to expect from this? I'm saying, let's not worry about this. Let's look now. It'll take us 12 months, not longer than that. Let's look in the next 12 months at practice-based evidence for all systems of medicine. From the ground reality, pick up the 100 best institutions in biomedicine, pick up the best institutions in AYUSH, use artificial intelligence and machine learning algorithms to analyze that data, and you will get a real picture of what is working on the ground. That will be your source, far superior to RCTs, because we know that in RCTs, all RCTs anywhere in the world, variability is not a factor that is taken into account in biomedicine. And so whether you do an RCT or a meta-analysis of RCTs, the sample sizes are inadequate, the inclusion-exclusion criteria do not accommodate variability as understood today at the frontiers of biology. At the frontiers of biology, we are talking of personalization of medicine. Why? Because we recognize variability. But that variability hasn't come into clinical practice, So that's all that I have to say, that no, the data is undoubtedly negligible, but negligible data is not an inference for incompetence. It is an inference for lack of investment. That's all.
Yes. So Darshan, you've put us, already set us to reimagine what we should be doing if we were to think of UHC in India. And I would continue with that to ask Dr. Porter what you would suggest we should be doing in terms of policy and research if we were to reimagine for a universal health system in India.
Well, I think Darshan in a sense has already started the
Imagining
around that. Yes, I think again, coming back to the biomedical model, the rational model, qualitative versus quantitative, these dichotomies that we sit within, it's really important to use the AYUSH systems and to investigate them in a different way, because they are the systems, the philosophy holds the biomedicine within it. So biomedicine looks for separation and difference. That's the nature of looking for disease all the time. It doesn't look for wholeness. It doesn't look for the bringing together. So all these issues around integration, lots of things that Gita works on, integration of systems. And so we need more information in about what's happening on the ground. And I think what's important from my perspective is to be using different disciplines. So randomized controlled trials in certain situations are important, but we have a wealth of other opportunities with qualitative methods, with economics, with health systems research, and so on. So to try and expand the way we look at these systems and their importance within universal health coverage is crucial. And we have to be innovative in the way we approach that. And I think also, with the way the market works, everyone gets caught with like evidence base, and then one gets stuck. So I think even the concept of practice-based evidence is enough to kind of put people off their stride and go, oh, what's that? And that's very important, because otherwise we tend to sort of sit in these particular sections. And certainly that's the way power operates. You train people to think in a particular way, and then it's harder for the other side to come in, which to me is a lot to do with the relationship with the fourth tier. So, and I think the wisdoms that we need to be working with, I follow an eminent American ecologist who died in 2009 called Thomas Berry, who talks about we need to find a new story. He's talking in much bigger terms, but I think that's true in healthcare generally. And the wisdoms that are required, he starts with indigenous knowledge. So indigenous knowledge is the first one. The second one is around the feminine. The third one is around cultural history. So all this incredible knowledge that you have in India of your systems that go back for thousands of years, we need to look at that. And then finally is science. And I think in his definition of science, kind of post 16th century, and demonstrating that science is the newest of those. And it needs to be supported by these others. And I think that's very true also for particularly Ayurveda. And for me, there are real concerns around the medicalization of Ayurveda. So the philosophy that we're working with is so powerful that it potentially distorts these broader perspectives that are crucial in the AYUSH systems. And we've, our team have written quite a lot about that. So those are the things that are important, keeping things really broad, the philosophy broad, and to be working on concepts, Sarika, as you said, of balance and wellness.
Yeah, thank you, Professor Porter, that you brought in that very effectively the need to reimagine not only the small things about the system, but the whole idea of what health is and what it grounds in. What are philosophies of looking at integrating not only with disease and interventions and programs, but broadly about our connections with the ecological aspects too. With that, Dr. Leena, could you talk this quickly about when we reimagine, how would you think should the socio-cultural perspectives come into the design and execution of a system? Like other panelists have talked about India being a nation. There are so many nations within a nation, and those local adaptations may be required. How would you reimagine in that context?
First of all, I think we need to recognize the regional diversity, as others have mentioned. And what is the nature of this regional diversity, and what kind of cultural practices, what kind of medical knowledge, and what kind of expertise, are available in different parts of the country, and then how best we can draw upon some of these resources to conceptualize as well as plan a universal health coverage program. Now, what do we mean by regional diversity? Because medical practices, knowledge systems are influenced greatly by the local culture, how the local language, literature, and culture have emerged in a particular region, and medical knowledge is closely linked to that. And one example is how Siddha medicine is closely linked to the Tamil language and culture, and then you find that that system has grown within that region. Then if you look at, say, for instance, the Adivasi, tribal or indigenous people's healthcare practices, they're very closely linked to the available local plant animal resources. And these practices also vary across these communities. And this rich medical knowledge traditions have eroded over the years because of certain policies which prevent their access to forests and to many of these resources. And of course, even in our modern education system, their knowledge and practices are kind of projected and portrayed as primitive and so on. So these healthcare practices struggle to survive in such a hostile environment. And you find that over the years, many of these practices have, knowledge traditions have eroded. Here, I'm not trying to romanticize, the tribal knowledge practices and traditions, but there are important practices which you can, incorporate from their traditions. Then you also find that the development of, systematic body of medical knowledge or medical specializations are different, in different parts of the country. For instance, the Vaidya or Vaidya medical traditions, what we call Ayurveda today, in the Bengal region was different from the way it developed in the Punjab region and in the Kerala region. So there are diversities within the medical knowledge traditions. And we need to really understand the what can be drawn from these traditions to be incorporated into while planning a local community-based healthcare system, and what can be probably drawn from some of these to design what you refer to as universal health coverage, which can be implemented across the country. Now, all practices may not be, because you don't have the resources available, the plant resources or animal resources available, to serve the entire population. So we need to really design taking the regional, differences and resources into consideration. So this is one point I wanted to make. And another point is with regard to what Dr. Potter referred to as, in the context of self-reliance and, So when one is thinking about, people's, self-reliance in healthcare, and when we talk about local population, we also need to keep in mind that, in our country, the local population is not a homogeneous group. They are divided across, by caste and class and gender and, many such divides. So how do we, think about a universal health care, keeping in mind the needs, diverse needs of these unequal groups? So I think it's also important to think about how do we plan for, improving the people's participation and increasing or enhancing people's self-reliance in healthcare in a very unequal context. I think that is going to be a big challenge. And perhaps we need to have some amount of research and studies into understanding, the nature of these power struggles and tensions, and what kind of healthcare practices can be then, can be sort of, encouraged, within such populations and communities.
Yes. Yeah. Thank you, Dr. Leena. That was really great to hear. How do we handle this diversity when we talk of universalization? Moving from there to hear what actually could be the pathways for improved roles for Ayush systems in India, in light of what could be learned from integrating the complementary systems or traditional systems in other parts of the world. And I think Dr. Pillai could talk about that, please. Dr. Geeta Krishnan?
Yes. In fact, instead of going around the world, I would like to, because of lack of time, I would think that I would get into what we, as our concept says, or the note says, or the title says, integrating Ayush systems into the Indian health system to improve our healthcare. I have three main areas which I think are extremely important if you want to achieve integration, which I think one broadly is health workforce. We need to make sure that our health workforce understands the requirement and the possibility by other health systems, which is very important, because if you don't, then there is no integration happening. Integration basically is a kind of a marriage between two systems or two kind of communities, and and an appropriate utilization of resources for the best outcome. And it could be in a clinic, it could happen in the society. When it happens in the society, we call it public health integration. When it happens in a clinic, we call it clinical integration. So that's only difference. But it requires people and knowledge systems to talk to each other. When knowledge systems talk to each other, it means people who are involved in delivering that knowledge system should talk to each other and make sure that it is best suited for the outcome that they are expecting. So that requires very specific training. And I think the kind of work which Niti Aayog is trying to do right now, trying to bring the integrative process together, is a first step towards that. And probably over a period of time in the next decade, we might see a difference there. Another one, we require solid programs. We require programs which says, okay, in these two areas, or in these specific clinical areas, Ayush or modern medicine is going to work together, or Ayush is going to take care of a particular program in particular situation. For example, as Dr. Darshan had pointed out, if 40 years of feeding iron tablets to women in India is not overcoming the situation of iron deficiency anemia in the country, are we still going to continue this for the next 50 years? do we have another option? And if that option is there, what is it? Therefore, we require comparative benefit analysis. And as Dr. Darshan said, if you look at probably the past 10 years of data, we might be able to come to that. And we require real programs. We require osteoarthritis, knee joint management. If you look at the data available in publications itself, there are hundreds of papers saying that traditional medicine has very good deliverables in terms of osteoarthritis, knee joint management. Why is it not available in our country? Why is it not available and utilized? And why are we waiting, having long queues of people waiting to get their knees replaced? The simple question, why can't we? We need to have real answers and real programs on the ground. And that comes to the third point, comes only from policies. It cannot, all policies cannot be based on the best of research available let us say, all the RCTs put together and done meta-analysis, and you have 100 meta-analysis, and then you come out with a policy. No, policies happen because you have an intuition and you have a knowledge and you have the basic understanding that things are safe. It is better to deliver because people will benefit out of it and it is not going to harm people. These are the simple things. If something is helping, something is not harmful, something is useful for the people and people are utilizing it, we should try to deliver it to the people and then look back and see whether it has been useful or whether it has been not useful. But the society has an understanding of what is useful, and it develops, that wisdom develops over a period of time. And that is not something which develops one day, in an overnight sensation. It happens over centuries. And that is what we are seeing in the, as expressed in our societies by the community looking for traditional medicine. So that should not be ignored and that should be taken into consideration. And the fourth one is innovation. I think innovation and use of technology is very important in delivering appropriate traditional medicine to people, because it is like, it is like the story of telephone lines in our villages. We didn't have, many of our villages didn't have telephone lines when the mobile phones came in. So when the mobile phones came in, none of these villages ever had telephone lines because they already got the mobile phone. It is much cheaper, it's much more easier. So similarly, we need to find a way of utilizing technology so that this knowledge can be delivered right to the people, and that is where it can be of great help in administering the fourth or implementing the fourth tier of health, which Dr. Darshan had been speaking, and it is already there in our national health policy. So these are my four thoughts. Probably there could be more, it could be wrong, but these are my four thoughts which I think should be looked at very seriously for achieving universal health coverage within India using AYUSH systems of medicine. Thank you.
Sarika, I will just come in for a minute here.
Please.
Very well said, Geeta, Darshan, John, Lina, everyone. And what Geeta was talking about, we need to do some major reforms in our own education system. For instance, if you go to China, traditional Chinese medicine practitioners and allopathic practitioners in China are in sync. Allopathic practitioners in China don't hate traditional Chinese medicine because they are sensitized right during their education period. So that kind of a training, cultivating the mind of medical practitioner, is also very important. And unless we address that at all levels, not only doctors, but at all levels, then the UHC progress will be easier. As far as EBM is concerned, evidence is not necessarily coming from experiments in laboratories, but evidence also come from experiences within the community and from insights of people. So we are not today ready to even look at it. Today, COVID has taught us that no system can monopolize this. Today, modern medicine, we try to monopolize in the early days of COVID, if you remember, AYUSH practitioners had no even access to them. But now slowly things have changed, and modern medicine and traditional medicine today are on the same level playing field as far as COVID is concerned, because it is new to both of them. So these new integrative models which will come up will be more humane and which will be really breaking these silos and this kind of monopoly which we have been facing for years together. But these deliberations which have been so far, are so enriching, and especially the fourth tie-up which Darshan and talked about, and John talked about, and Leena extended it further for the cultural linkages. And although Geeta focused on the local issues very nicely, I must tell you that globally, and he may really like to expand quickly, just to give context, Geeta, that in other parts of the world also, people are looking at traditional medicine from different view. So thank you.
And Dr. Geeta, would you like to come in here?
Yeah, in fact, looking at traditional medicine from other parts of the world, let us say African region would be one good example that we can look at. Starting from like herbal medicine is a major component of health delivery in Africa. And if you go to any of these countries, for example, I had been fortunate enough to visit Ethiopia and try to work around with few of the like medical practitioners there for about a week, and I found that like the kind of interest for or belief of the local tradition on the local traditional practitioners on for getting the health delivered is quite huge. And it's similar is the case with other countries, like you take Malaysia, where there is a Malaya health system which is very well entrenched in the community, and Malaysia also has an open system where they accept other systems of medicine very easily, or they have already created the structures for other systems of medicine to come in. Whereas neighboring country of Singapore has a very like cautious approach towards traditional medicine, even though it gives all the honors or keep all the honors of delivering safe traditional medicine to the practitioners of traditional medicines itself. So it is extremely a precarious situation for the practitioners of traditional medicine in Singapore, because there aren't enough regulatory systems which can cover for any kind of flaws which will happen. Whereas in Australia, you already have several systems of medicine, including traditional Chinese medicine as well as Ayurveda, even being taught there, with specific curriculum and very specific areas where Ayurvedic practitioners or traditional Chinese medicine practitioners can practice. Similarly, in Netherlands, there is no system. Actually, Netherlands does not cover traditional medicine under any regulation, but there are certain activities which only a registered medical practitioner can perform. So they have this rule which says that certain kind of surgeries, certain kinds of medical interventions can be done only by a certain group of people. Otherwise, it is entirely open for the practitioners to practice there any system of medicine, and even the insurance covers it, like as long as it is according to the approved training programs within the country, or even by the WHO. If for example somebody is practicing Ayurveda in Netherlands and who has been trained according to the WHO standard of training programs, their practice is accepted by the system and actually supports them with financial benefits. So I don't know whether I covered it as what Dr. Bhushan wanted it, but I think what we should understand is there is a lot of diversity in social acceptance of traditional medicine. Some of them are inherent because this traditional medicine is already available in the society and it is very easy for people to accept it. Whereas in certain societies, for example, let us take a society like United States of America or even Great Britain, it is not available within the society as traditional medicine itself. It is totally traditional medicine in these societies are modern biomedicine. It has evolved over a period of time, and in 16th century, on 17th century onwards, traditional medicine means modern medicine, and that is what they are doing. So they are trying to get something from outside and putting it into their society, and they are very careful about it. But still, it depends upon how the world view of the community is that the traditional medicine is accepted. Sometimes the world views are totally against anything that is foreign. it is very difficult to get into that society. They don't believe anything outside. They don't believe anything that is coming outside their social structure. They cannot accept it. We cannot complain about it. That is how the makeup is. That is how the makeup of the social thoughts are. But it is very, and therefore in such cases, we will have to go behind strong evidences which they will consider as evidence and allow us to get in. But the question is whether we should, as a community, try to get into other communities and try to make their life better rather than trying to introspect and use our information and make our life better. I think we should first try to do that, because we have enough and more people in our country who requires our help. And I think traditional medicine can do a lot in this particular context.
Yeah, thank you, Dr. Geeta.
I just wanted to say that there were several questions in the question and answer section.
Yes, sir.
I'm coming some of them, and because there may be a time limitation, I have also given a lot of resources which will give answers to some of those questions, especially what is integrative medicine. And these questions, we need not take them to the panelists, but those who are interested may just refer. I've just put them in the chat box. There was one question by Dr. Oliver. I have also addressed that question. He was asking about the case report format specific to Ayurveda, and recently Ministry of AYUSH has launched a clinical case repository, and I have given a link to that repository. Slowly, the deposition of cases in this repository is growing, but we'll have to do a lot more awareness and encourage people and train people to put these experiences in proper format. And with this last point from my side, Sarika, I just wanted to tell that we always keep on asking question about evidence from traditional medicine. The onus of this evidence, I feel, as a researcher, I am also a researcher, not a traditional medicine practitioner. But this doing research should be on us, as researchers. We cannot ask this question to traditional medicine practitioner, what research you are doing. We cannot ask this question to Siddha practitioner, Ayurveda practitioner, what research you are doing. We should ask this question to biologists. We should ask this question to chemists, what research you are doing in this. So this kind of a wrong expectation management also is one of the predicament towards the universal health coverage process. And the philosophy, what Dr. John also talked about, this is another important piece in this to build more robust evidence. Of course, it is connected with the funding, what Professor Darshan talked about. Now, I think you may address few questions which are still hanging, and we can move towards the conclusion of the program. Thanks.
Yes. So, just before that, Dr. Pune, there's a question on ethics, and I think you being a public health practitioner and trained in ethics, would you comment on the public health ethics of choosing interventions for health systems? One of them talks about when they achieve and effective interventions available, why would a health system or a program choose one over the other from a public health ethics perspective? How would you say about that?
Well, it comes back to my point of which philosophy are you sitting in? And it's then to do with power and process. And also, as Geeta said, it's then also to do with policy. And as Bhushan's brought in, the whole importance of education. So the more open-minded and well-educated, you could say, the population is in terms of how it sees things around health, the better. Because it then provides the population with a better opportunity to actually see what it means if you have a particular intervention coming in. So a particular biomedical intervention, for example. Let's talk about disease control, which is my issue at the moment. Or basically has been my training. But I think in terms of ethics, so the obvious one for me in the UK at the moment is around vaccines for COVID. So it's either you do or you don't. And then there's all this political stuff that goes with your decision as to whether you're going to have a vaccine or not. And for me, there's remarkable little information around who these vaccine deniers are. What is their story? So, when I hear Lena talking, I think, oh, it'd be wonderful to have her over here going into these communities and actually finding out what the issues are. Because what I find is that our perspective, for obvious reasons, I mean, it's very powerful in biomedicine and control, and in many ways we're doing very well in terms of the epidemic with vaccines, but we're looking at it in a very narrow way. And there's all this space around the broader philosophies, which includes all the AYUSH systems, that are really not being used appropriately. And I would say that is an ethical issue at the end of the day. So ethics needs to open up. It helps us open up space, in a sense, in these particular debates. And polarization, which is what we have so strongly in politics in the West, and you can see it strongly in the vaccine side of things, is all very well, but it really doesn't help us get anywhere other than to violence and to war at the end of the day. So where is that discussion? Where is that integration process? And then I come back to basic values around dignity of individuals, respect for others, and trust in communities. And if we really sit in ethics in terms of if I'm a biomedical practitioner and I know nothing about Ayurveda, I have the opportunity when I speak to an Ayurveda practitioner of completely changing my world if I sit and really listen to what they're saying, because that's the nature of, the balance of respect and deep listening. So for me, that's, a key part of what ethics is about at the end of the day. And I think we need to constantly be aware of that and increase our awareness and consciousness of those processes.
Yeah, thank you, Dr. Porter, for that reply and disrupting some of the concepts of what consists ethics for policymakers. There are questions which have been answered and some haven't been due to the paucity of time. But I would come to each of the panelists, including our keynote speaker, to just give one quick remark on what you would think India should do to integrate the AYUSH move for universal health coverage. Just one quick comment and we can close. Dr. Darshan Shankar, please.
No, I don't think there is any requirement. I think the Lancet Commission should really be looking at Indian policy. There is no requirement for, the policy is very good. The policy of 2017, the policy implied in the National Health Mission, the policy framework underlying the Ayushman Bharat. We have the right policy now, which is integrative in its outlook. Our challenge is to begin to operationalize this policy in terms of education, in terms of research, into new models of research, new paradigms of research, bring it into education, bring it, as Geeta Krishnan rightly said, into training of our health workforce, and so on and so forth. So our problem is, strategic moves towards operationalization. The policy framework is there.
Yeah, and Dr. Porter and then Dr. Geeta Krishnan, please.
I would be encouraging you in terms of the aspects of nature. So I think it's really important in the policy also that we start to link all our health work with issues around the ecosystem and the changes that are happening in the ecosystem. So I think I have this discussion. What is the conversation between what I call technology and the indigenous, which includes the plants? That's what I'm working with at the moment. I want to know what that conversation sounds like.
Yes. Yeah, Dr. Geeta Krishnan and then Dr. Leena.
I think the government should take a decision to undertake at least one program in each of the AYUSH systems to be delivering that in the public health sphere across the country. One single program, let it be an unmet need identified and found to be beneficial, more beneficial, comparatively more beneficial in that particular system. One single program, one single an intervention management, program, whatever you want to call it, for one single aspect of healthcare necessity within the community to be delivered by one system. And that should be done, that should be observed, that should be identified, and that should be flagged with all the data for the next 5 years, and then see what is the result. And then let us talk. I think that is what I would suggest. That's if you ask me one thing.
Yes, yeah. And I'd be happy if that happens, Dr. Geeta Krishnan. Dr. Leena, would you make one quick suggestion to the Lancet Commission on this?
Yeah, I think to me, one of the biggest challenges, how to improve communication and dialogue between these systems. The field data suggests there is a lot of communication, integration, and happening because people are integrating, learning about other systems, practitioners. Biomedical practitioners prescribe proprietary Ayurvedic medicines. Then they utilize Ayurveda for their own personal health issues. They try to learn from, family members and other groups. There's a lot of informal conversations happening. But how do we bring these conversations into a formal fora is one of the biggest challenges. And I think there is a need to work on that. And one suggestion is to introduce these medical systems, some of their principles and concepts at the school level itself, because we go through an entire schooling without knowing anything about these systems. And how do you then challenge, question, critique, or even understand these systems if you do not have any basic familiarity with it? So I think this is important to think about how do we introduce some of these themes in our school curriculum. So the students have to go through this curriculum, and then suddenly after their 12th standard, when they join their, AYUSH medical education, they have to make these, epistemic conceptual shifts, which often remains incomplete and partial. And then you end up producing a workforce, with trained incapacities. So I think we need to address some of these issues quite systematically at the level of education and training. Thank you.
Thank you, Dr. Leena. And now I would request Dr. Patwardhan to make some closing thoughts. Concluding
thank
remarks.
you, Sarika. Very well organized. This was really a brilliant webinar, I would say. All the speakers have given excellent presentations, starting from knowledge content issue, biomedical dominance and medicalization, to philosophy of universalization, to cultural links and to people choices, pluralistic practices, global scenario, evidence-based medicine, and actually how to translate that in practice for the USC. We could cover in a short time most of the important and key factors related to role of AYUSH in universal health coverage. I must thank my all fellow commissioners and chairs for allowing us to have this wonderful webinar. And with this, I wish you all the best. Stay safe, stay healthy. Namaskar.
Thank you, everyone. Thank you, all the panelists, and thank you, all the viewers.